Good morning. I'm Rob Georgi with the FBI, Special Agent with the FBI, and I brought along today.
Hello, Dan Aragnosi, Special Agent with the FBI, primarily work healthcare fraud.
I'm Molly Duca. I'm intelligence analyst with the FBI, and I assist Dan over here with healthcare fraud issues.
Now, your executive management has been kind enough to give us 5 minutes today. We won't take more than 5, okay? And you're a very busy day. I don't want to interrupt with your ICUs, your ICPs, or any of the other things that you guys get. We just want to do a quick pitch to you guys as to what sort of trends are going on out there right now with healthcare fraud, items you can look for, and things you can call us on if you get any concerns, because you guys probably know Medicare's $700 billion a year right now in annual billing in the U.S., and I've been in meetings where their executive management has said, we're comfortable with a fraud rate of about 10%. So as taxpayers, we're all taxpayers here. That's $70 billion a year that folks are ripping off our Medicare system. And we also deal with Medicaid. We deal with all the private insurance agencies. So we've got 5 hot buttons we want to leave you guys with today. And then that number up there, if you put on your 3D glasses, it pops out at you. Okay, that is 493-8688. That is our number here in the Omaha division. That's to our 24-hour switchboard. That way you don't have to remember my number or Dan's number or Molly's number. You can just call there. You don't have to remember Agent Aragnosi is our primary healthcare fraud investigator. So if you get something you want you want to talk to an agent about, you would call over there and you can just say, can you give me Dan at 493-8688. We're a small enough division, they'll be able to find him. If you ask for Molly, that's a problem, because we have 2 other Mollys, and that'll be a problem. Or you can call me and just say, can I talk to Rob? I'm the only Rob in the office. Okay, first item, Dan, what do we got?
Prescription pain medication abuse.
Prescription pain medication. We hear, particularly when we cover Iowa and Nebraska, big time problem with prescription pain over medication, or folks who will go in and doctor shop. If you go into a patient's home and you see there is 8 hydro bottles from 8 different doctors, or 6 Oxycontins or alprazolam, and you get concerned, give us a call and we'll do an evaluation, okay? Or if you see a doctor is prescribing way too much to your patient and you say, 40 milligrams would be a lot more appropriate. Now, we recognize you don't want to always challenge the doctor's diagnosis, but you guys are all professionals in here. You should be able to recognize if somebody is being overly medicated or somehow abusing the system. What's number 2, Dan?
The properly diagnosing the patient.
Properly diagnosing. Sometimes we will have folks who, with the intent of fraud, will go ahead and elevate a diagnosis with the intent of somehow getting money back through the system. Be it Blue Cross Blue Shield, if they diagnose somebody as completely bedridden and they need the following services, and as you're walking in, somebody's walking out with a massage table because their prescription was for daily massage, and you say, this guy's got a broken arm. What the heck is that massage person doing? That's the sort of stuff where, now that example is extremely blatant. The stuff you would encounter would be a lot more subtle. Good. You guys are really good. Subtle. Dan, what's number 3?
A patient that's billing Medicaid, Medicare, who doesn't appear to qualify for those programs.
Okay, let's say you get into the house and you know this patient's being billed for Medicare and you say, how old are you? I'm 37. That's a little odd. Or let's say you go to a luxury house and eventually you get around and you figure out this person's on Medicaid. Now, there are certain situations where that could apply, but that would be unusual. You guys are aware you have to have certain levels of income in order to qualify for Medicaid. Those are the type of things where please call Dan and say. Now, let me say, we're well aware of HIPAA. We know there's stuff you can tell us, stuff you can't tell us. Please don't deliver a shoebox full of patient records to our office on the door, ring the doorbell and run. We don't want you to do that, okay? We know what we can take, what we can't take. We probably wouldn't want to know about patients' records and diagnosis. You can give us doctors' names. You can say, hey, you know what? Something's weird with this patient, and then we can take it from there. We'll have some follow-up questions with you. Number 4, Dan?
The durable medical equipment. I think we all know about the wheelchairs and such.
That's a big, big problem nationally. is folks who do not qualify for certain specialized equipment, beds, electronic wheelchairs, and they might have a deal with the distributor, they might have a deal with some sort of underhanded home health care provider. If you get into a patient's home and you have to climb over every time because there's 4 electronic wheelchairs between you and that patient's bed, let us know, okay? Those are some high-ticket items, and those are constantly abused. The wheelchairs are just giant for us. And our last one, Dan?
Then services rendered or more not rendered, and then the unbundling and bundling of the codes for the services.
Right. Now, you guys work for a reputable company, but you may have, in the past, worked for a company that wasn't as reputable. Or maybe you've got a friend who works for a company and they say, you know what? I'm in there an hour a week, and yet the patient, I see bills saying I'm there 20 hours a week. Or, you know, I provided this service and I've seen the patient, or the patient will ask you, hey, can you sign this form for me? Or anytime you get anything that makes you uncomfortable in a professional billing situation, that's the type of stuff that we want to hear about. Now, we only have 5 minutes, so we don't have time for questions today. So you can happily, and please do, 493-8688, or if you lose that number, you can Google it, and that is our main switchboard number here in Omaha. Ask for Agent Dan, ask for Aaron Yossi, ask for the healthcare guy, ask for Molly, the healthcare girl. You can do any of that stuff, whatever you want to do if you need some clarification or if you get in a situation where you think there might be some fraud, because just as I said, Medicare alone, $70 billion. That's a lot of money. Medicare too. Okay? I kept it to 5, didn't I, Barb?
You did. Good job.
Okay. Have a great day. Thank you for listening.
Also, I'll leave some business cards up front, so if anybody needs one, or if you need more, just get a hold of us. I'll drop some more off for you.
Fantastic. Where are you going to leave this, Dan? Over on the side?
Yeah, somewhere up here.
Great. We're going to get a tour of your facility while you guys are getting trained in here now. So hope your desks are all clean.
What test?
Thank you, guys. We appreciate it.
Thank you.
Well, that was fun. And someone just commented that he was easy on the eyes too, so that helped as well. All right, I wish he could stay. I mean, that was perfect timing because, and not just because he was handsome, but when we had this, scheduled, and then FBI contacted us and said, hey, we want to talk about some current trends. With my heels, I'm slightly taller than him, so I'm kind of hunched over. Well, I'll lean. Bad posture, sorry. So it was perfect timing that he wanted to, talk with us about some abuse and neglect and some fraud issues and for our vulnerable adults. And so I, unfortunately, have kind of the most boring part of today's presentation because I get to talk a little bit about our policy. Boo. But we have one, and it's important information to know. And then after me, we'll have our featured speaker, Audrey Kruger from Southwest 8 Senior Services, which is over in Council Bluffs, and so she's going to specifically talk about self-neglect. And so that will be a very interesting topic for us to hear about. Now last year when we have, this is an annual in-service, and last year we did have someone come talk and specifically talked about child abuse, and this year it's more focused on elder abuse, and I think we are all well aware that whether you're a maternal child nurse or whether you're in home care or hospice working with the elderly, many of our homes have multi-generational and have many family members in there. So it's very important for all of us to be aware of all types of abuse, whether it's for children or for adults, and not to be in tunnel vision, but be aware of what's going on with all of our families and surrounding our patients. So with that, I'm going to go briefly through some stuff. I have a lot of slides. We're not going to highlight all that information because it is in our policy. Our policy is adult child abuse reporting and identification system, and it is applicable for all those in home care, hospice, family services, personal care, and support. So whether you're in home aid, you're in hospice, you're in home care, maternal child, varying from a dietitian to a home health aide, all the way through to nurses and everyone in between. We are mandated reporters, and this policy applies to everyone. And all our policies are located where? Right, 2 places. The Right to Know Center, which is right across from the pharmacy, and then also on the intranet. And so you can access all those policies. So whenever a surveyor happens to come through and says, do you have a policy on abuse and neglect? Your answer is
Yes.
And even though you can't recite the number of it, you will say, but I can find it. Right to Know Center or on the intranet, and that's what we need to know. This policy says that it is our job to make sure we protect our patients to its best abilities, and that is, again, not to be in that tunnel vision, but be aware of what's going on, and if we do suspect abuse, that then we do report it. The gentleman that was here had mentioned about HIPAA, and yes, HIPAA is very important, and we do follow that to a T. But it does say that with HIPAA that if there is a suspected case of abuse and neglect, we can report it to the law enforcement or the Department of Health and Human Services. So think about your patients. You know, those who have been in home care, I will just take a little poll. Who has made a report to Child or Adult Protective Services? Raise your hand. Okay, if you kind of take a look around, you can see that it's a pretty common occurrence, sad to say. But we are the advocates, and lots of times we make the report and it turns out well. You know, we've made the right decision in doing that because maybe there was some neglect and they needed further community support and services, and we get those involved, and it ends up being the best case scenario and a positive one. In some situations, it's very sad, and I think you kind of think of the extreme in abuse and neglect. And there was a case recently with a gentleman that was allegedly neglected his mother, who ended up passing away, and I think you're probably all familiar with that. Those are extreme cases, but it's all the gray cases that I think was where we kind of struggled. Do we report it? Do we not report it? What should we do? We'll talk a little bit about that. Neglect, and I'm not going to go into a lot of this, but this is, again, all on the intranet. And you have active and passive, and this is kind of interesting, I think, because you have the active neglect where you have a caregiver that is capable of caring for someone and is intentionally not caring for them. Or you have the passive, maybe it is a husband and wife that maybe have some cognitive deficits and they have a child, and just because of the lack of knowledge or lack of education is doing some passive neglect with that patient. So we become involved and we do some teachings and we're able to turn the situation around. And then physical abuse, which of course is that intentional harm, psychological or emotional abuse. And again, I think some of that can be very, very obvious. You go in the home, the son comes in, he's frustrated, he throws some curse words at his elderly mother, or some that are not quite as clear that. You kind of think it, or is that just the dynamics of the relationship? They've been married for 60 years. Has he always treated her that way? Is it okay that he treats her that way? Those are all the questions that we continue to have, and why it's important to discuss with your social worker, with your team members, to get some more information. And sexual abuse, violations of basic rights. I think this pertains a little bit more to a nursing home situation when someone isn't allowed to have the freedom of religion or privacy. But I know if you think about in some of those multi-generational homes, someone was just talking about a patient, an elderly patient, who had her daughter, and the daughter had her daughter, and then a bunch of kids, and she went to see her, and the patient, who was confined to the bed, and there's kids running around everywhere. There's no privacy for her to get any of her treatment. And it's just something to kind of think about. Is that really the best situation, and what can we do to right that? And then self-neglect, which Aubrey will talk a lot more about. Our policy says that it's an ongoing assessment. So when we admit a client onto service, of course, we're assessing everything. And then ongoing. Again, it's not that tunnel vision. It's a therapy-only case. We're not just there to treat the shoulder. You're also seeing what's happening with the children that live there, or the grandma that lives there, and all the situation that's going on. And we are required to identify and then to report. We kind of talked a little bit about that passive and active neglect. Just some possible indicators, dehydration, pressure sores. It's important, obviously, that you do a full evaluation. Just because someone has a pressure sore doesn't mean they're in a case of neglect. That's why it's important to make sure you don't jump the gun and have a full assessment. That doesn't necessarily mean that you walk in and there's obvious signs that you don't make the report yourself. You don't need to call in a social worker to tell them that someone's being abused and have the social worker make that call. Our eyes or our ears hear it, we're the ones that need to make the call. Physical abuse, the obvious signs there, again, all on our intranet. Psychological abuse, you've seen those patients that when you're talking with them, maybe at first maybe kind of be withdrawn, the son is there, the son leaves, they perk up a little bit, they start talking more, the son comes back in the room, woo, they start to be withdrawn again, they kind of look down, don't make eye contact. Starts to get a little red flags. Is there something going on with that relationship? And it's just something to be aware of again. So something that maybe you say, hey, I want a social worker to come in, do a further assessment and analysis of that relationship, talk with the patient maybe in private, maybe arrange for an appointment in private, or a time where that son wouldn't be there to see if you can gather some more information. Sexual abuse, again, good nursing care 101, skin integument. You're going to look and do a full head-to-toe skin assessment. And that's for pressure sores, bruising, everything in between, because our job is to make sure that we are fully assessing our patients. Emotional abuse, again, kind of like that psychological abuse. The signs and symptoms of neglect, unsafe living conditions. I think you can think about all those situations where you go in, and again, to have that conversation in your mind of, is this their choice? Is this okay? It's not how I would live. Let's not judge. To the line of, okay, now it's crossed the line. And there's, we've talked with the daughter. She needs to be present. Need 24-hour caregiving. But yet when I showed up at 3 o'clock, an hour after I was going to be there, she wasn't there. Now, is that neglect? Are we, some things that we just have to continue to assess and to think about. Financial exploitation or improper use of one's funds. They've talked a lot about that. We have this Medicare fraud. How many times have, you've seen the scooter, whatever, ads that say, oh, you'll qualify, and oh, it's easy. And I know from a physical therapist standpoint, they said, we had an agency contact us to evaluate patients for scooters. And we would go to the home, and the person's walking around, and they're like, I just want one to go to Walmart. Well, that's probably not the greatest use of Medicare funds right now, when you think about it. So, people just, they're driven by money. So you can be thoughtful of that. But then also you can think about those patients that have someone that's caring for them. You know the story where they say, oh, it's a friend's niece, and she's coming 3 times a week to help me clean, and you walk in and the place is a disaster, and oh, what does she do when she cleans? Oh, she's here for about 3 hours, and oh, and she's a single mom, and oh, she's going through tough times. Can I just give her a little bit of extra money? And maybe that person isn't being taken advantage of, and this person is just being nice. But think about the situation again. You have a vulnerable adult, maybe they're isolated, and it feels really good to have someone come and care for them, and they're really nice. But is that person taking advantage of the situation? These are obviously obvious ones. We do have people that report that a family member has, is taking their checkbook and some things like that. Obviously, those are very obvious. Who should report? I've mentioned this before. It's everyone. We're all mandated reporters. So your social worker, your nurses, PT, OT, speech, home health aides, dietitians, we're all responsible. When it's not black and white, use your social worker. Bring her in, have the conversation, talk with your manager, have a team conference. What you see one day might not be what another person sees the next day. So we don't want to jump the gun, but we also don't want to just kind of sit back saying, oh, well, we'll just have somebody else evaluate. You really need to use your best judgment in those situations, but that's why it's so important with a team assessment. We are all required mandatory reporters. Nebraska state law states that we have to report, and then Iowa designates certain people that are absolutely mandatory reporters within a 24-hour period that if we suspect it. And so those in healthcare, education, childcare, mental health, law enforcement, social workers, so that is us, that includes us. And failure to report is a crime. in Iowa, you could be civilly liable for that if you suspect abuse and do not report it. It is a crime. So what do? We want to make sure we gather all the necessary and pertinent information, consult with your team or manager. And I think possible cases, the worst case scenario is you make a report in the best interest of that person. They do an investigation and everything is fine. That's the worst case scenario, which is not a bad scenario. Make sure we document that we made a referral on APS in our record. And then there is a disclosure log that's on the forms wall and on the internet. And we do need to put that in the medical record when we make a report to CPS or APS. Here are the numbers for Nebraska, and that's also on the internet, Iowa, and then for Pot County. I'll let you, it's on the internet, and I think Aubrey also has those hotline numbers in her handout. Yes?
Pot County refers it to the 800 number. They're all taking all the reports in Des Moines.
Oh, okay. Jean just said that Pot County now refers to that 1-800 number. So Jean, do you just only call that 1-800 number then?
Yes.
Okay, only call that 1-800 number. And that is in Aubrey's handout. There is also a list of resources for domestic abuse resources in the Right to Know Center. We do have a list of private and public community agencies specific for domestic violence. And again, just to mention that to make sure we utilize our social workers, utilize their expertise. Anybody have any questions? So the VNA policy, we're all mandated reporters. We have a policy on identifying that it's our responsibility to identify and to do an ongoing assessment, to report it, make sure we consult with your team members, document it in the clinical record, and then fill out a disclosure log.
How old does a person have to be considered an elder?
How old does someone have to be considered an elder? Aubrey can answer that question. I'm passing the buck.
Okay.
Here, I'm gonna-
Actually, in Nebraska and Iowa, we have vulnerable adult and dependent adult laws. So anybody 18 or older is considered to be either a vulnerable adult or a dependent adult if you believe somebody is being abused or neglected. Those laws aren't specific to seniors.
The reason I ask is I did contact him one time because of a daughter and pushing her mother down the stairs. And the mother had reported that to me. But when I called the agency, they told me that she was considered a responsible adult, and so it didn't apply for her.
It's not bad to ask for somebody else.
Well, yeah, and the problem with that is with both states, the laws that they have, is to, I will get this figured out, to protect our most vulnerable adults. So if you have somebody who is confident, able to make their own decisions, and they can perform their own health cares, then APS usually will not get involved. Did you guys have any more questions for Amanda before I come up here and totally take over? No? Good? Okay, good. Good morning, everybody.
Good morning.
I am Aubrey Kruger. I work for Southwest 8 Senior Services. Does anybody know what Southwest 8 is? Good, good. We're the Area Agency on Aging in Southwest Iowa. So if you're familiar with the Eastern Nebraska Office on Aging, or ENOA, we're the same thing. It's just we serve Southwest Iowa instead of the area that ENOA does. I've been working in the aging field since 2001. When I first got out of school, I was going to save the world and work with teenagers. That lasted about 3 years, and I couldn't do it anymore. I had a friend who told me about a job with the RSVP program in Council Bluffs, and I got into that job. I started working with seniors, and I just loved it. Boy, what a difference from working with somebody who likes you and appreciates you from working in a youth shelter where they threaten to kill you. So seniors, I've really enjoyed working with. I started with Southwest 8 in 2004, and when I started with Southwest 8, I kind of had the advocacy position. And that meant I worked with our volunteers, I worked with our elder abuse program. What else did I do? I had like 6 different programs. And once I really got into this, and I started working with some of the folks at the state, I thought, oh my goodness, we really need to have an elder abuse prevention program full time. So through working with my wonderful supervisor, Kelly, we were able to write grants and get the funding through the Iowa West Foundation to start working on an elder abuse prevention program full time. So I think by that time it was like 2005, I want to say, we were funded through Iowa West. I could actually go out and work with APS, because the thing about APS is they don't have the money for the direct services. Our program did. So if I had somebody who needed an exterminator because their walls are covered with roaches, we could pay for that. Or the mice, or they needed a dumpster, we could provide direct services, and that's what we did. After doing this and kind of modeling the Iowa program that they had of the Elder Abuse Initiative, finally in fiscal year 2007, we wrote in an RFP to the state and we ousted one of the programs that had been functional since 2000, and we became one of the 4 state-funded programs in the state of Iowa for the Elder Abuse Initiative. Which meant even more service dollars to help the folks that were in abusive situations but didn't exactly fit under, in Iowa, it's DHS, Department of Human Services laws. So we could go in, and if the people were receptive, we could get them services. When I started this, I think I was probably about 6 months in. I had my first 2 concurrent courting cases. And it was funny because they were both in Pot County. One was in Carson and one was in Carter Lake. And coming from working with teenagers in a shelter situation to working with these 2 hoarders in their homes, it was like, wow, what do you even do? I was fortunate that year, and I went to the Iowa Governor's Conference on Aging, and I got to listen to this wonderful speaker. Her name is Wendy Lesvader, and she is actually a social worker out of Oregon, and she does a lot of work in home and clinical with people who self-neglect. And just listening to her kind of helped me be grounded, because I was at the point right now, at that time, where I was just ready to run away, because if any of you guys have worked with folks that self-neglect to the point where it's not safe for them, you know it's very hard. It's hard to get them to accept services. It's hard to get anybody else in the community involved to get these people in a safer situation. So I was lucky to be able to listen to Wendy and say, okay, how can you work with folks like this and preserve yourself, preserve their rights, and get some action going to get things better in their life. Since 2007, I have worked with just short of 1,400 clients. I think the actual number was like 1,379. And of those clients, 787 of them were classified as self-neglecting. So I'm not a licensed social worker. I didn't really go to school to learn how to work with these folks. It was kind of like, you know, learning under fire. How do we best treat these people? Okay. I am going to talk to you guys more about what is self-neglect, what are some of the characteristics of the people that self-neglect, why do they do it, and then working with the self-neglector, how to protect your client and protecting yourself. The National Adult Protective Services Association defines self-neglect as a result of an adult's inability due to physical and or mental impairments to perform essential care tasks. And you have it right there in the handouts. They can't get the goods that they need or the services necessary to be safe in their home. And as Amanda pointed out and kind of went over, when you have somebody that's self-neglecting, sometimes it's active, just like with their caregivers, and sometimes it is more passive. A lot of the folks that I deal with, maybe we have some mental illness going on, so they don't even realize that what's happening is not right, not the social norm. Or sometimes you have folks that just don't even care, that this is how they've always lived, their parents hoarded, their parents had roaches, and that's just normal. So how do we treat these folks? When you picture the typical self-neglector, usually they live alone, they're female, they suffer from some kind of confusion or depression, they may have alcohol or chemical dependency issues, and a history of poor personal hygiene or living conditions. And that's also true for elder abuse in general. When you see the typical abuse victim, usually they're women, and I think they're usually 79.5 years of age, and they live alone. Signs of self-neglect, lack of self-care, lack of care to the home environment, hoarding. I was going to talk more about hoarding, but there's so much out there on hoarding right now. It's like the new it thing with all the hoarding shows and all the information online. So I thought I would just focus more on self-neglect. Hoarding is a part of self-neglect. Lots of times people isolate themselves when they're a self-neglector. They don't want people in. They won't let people in their homes. They aren't taking care of their financial stuff. Good example, I have a fellow who, instead of paying his rent every month, he's going to put money on his special cell phone so he can talk to all his buddies in prison. So he's going to spend $500 a month on this cell phone to talk to his buddies in prison instead of paying his rent. And then, oh gosh, what am I going to do? Well, okay. And then denial and resistance. Many times when you're working with the folks that are self-neglecting and they have the mental health issues going on, they don't see that they have a problem. They think that who they are with their mental illness should be accepted and should be okay even if they're totally outside of most societal norms. Lack of self-care. The same fellow who doesn't have the money to pay the rent because he spends all this money on his cell phone, he doesn't have electricity in his apartment. Okay, no, he has electricity in the bathroom that the neighbors pay for because somehow it's hooked up to the wrong apartment. And so he has no electricity, but somebody's paying for it, so he don't care. If you go into places and utilities are missing, no air conditioning, no heater in the winter, lack of hygiene. I have folks come in all the time and I can tell that they have some self-neglect issues going on. And I hate to be blatant, or they're just trying to, when they come in just for simple help, like, oh, I want the number for an attorney because this contractor is ripping me off. But their clothes are stained and they obviously haven't bathed for quite a while, and you can smell them across the room. Just indicators that they aren't properly taking care of themselves. The failure to eat or drink properly. When I was first learning about this, they said one of the biggest indicators for healthcare workers is somebody is presenting at the ER being dehydrated. They aren't drinking. Either their caregiver's not giving them the fluid that they need or they're not taking, but being dehydrated is a big indicator that somebody is in an abusive situation. And then also the failure to comply with medications and treatment. Okay, lack of care to the home environment. I heard a couple of you were coming in kind of joking about this. Oh God, I don't want them to see my kitchen. Well, I don't want them to see my kitchen either, or my car right now for that matter, my goodness. But typically, when you're in with somebody who self-neglects, their home's very disorganized, cluttered, maybe not to the point of hoarding, but to the point where it could become a major concern if they continue on the path that they're going in. Maybe the normal repairs of the upkeep aren't being done on the home. Lots of accumulated old dirty dishes, animal feces and waste, vermin present. I had one lady, and I at the corner of my eye, you know, you could see something. I'm like, honey, do you have mice? And she's like, oh yeah. So that was good. And just being mindful, because they're not always right there. Sometimes they're running along the side. And the hoarding of items and animals, which is, you know, the most obvious form of self-neglect. You know, as healthcare providers, good functioning members of society, I many times get, why would people do this to themselves? Why? I don't understand how people could let it get this far. Well, there's 3 major contributors to that. It's either physical, mental, or financial. I already talked about this, but the untreated mental illness is the big one. They may have depression, grief, they've lost everything in life, they've lost their will to survive. I had this lady who was 102, and she's like, honey, I have lost everybody. My children are gone, my grandchildren are gone, I have nobody. Why should I go on? Why is God keeping me here when He's taken everybody that I love? And just kind of talking to them, it's never an easy thing. Okay. Physical indicators, again, the people usually live alone. If they don't live alone, they usually live with a child. Isolated, maybe some of our folks, we have a majority of my service area is very rural, except for Council Bluffs. They live out in the country, their nearest neighbor is 7 miles away, there's nobody there for support. They can't drive, or they shouldn't be driving, and they have limited physical abilities. Okay. The mental reasons, anytime you have any sort of dementia going on, or a low-grade infection, or hormone imbalances. I had a lady once who she was not taking her medications, very confused, and this happened all of a sudden, and nobody could figure out quite what was going on. And after finally getting her to the ER, they found out that she had a bladder infection that had not been treated, and that it had gotten to her bloodstream. And once we were able to get her into the ER and into the hospital and get that infection treated, she was then again able to function normally. Chronic depression is very big among the elderly. If it's not treated, they just don't have the will to do what they need to do to function in society. And then alcohol or other substance abuse. And I'd like to point out, with abuse in general, anytime there's alcohol abuse or substance abuse in a household, either by an elderly person or by their caregiver, the chances of abuse in that home go up to 85%. So that's a good thing to be watching out for. Some of my clients, their family's a little bit more blatant. They'll leave their bongs and their pipes out on the table. But sometimes the family members will actually say, you know, Jimmy's smoking pot all the time and he doesn't really take care of me. With the financial, that's kind of the harder one to help, and that's the one that falls more under the passive. The folks, they don't have the resources to do what they need to do. They've been in their house for 50 years, and they just, with the cost of everything going up, they just can't afford anything anymore. So they don't get their medicines. They choose to buy their cat food instead of buying their own food. They pay, just making decisions that aren't the best for them, but they're trying to take care of the best they can. and I skipped ahead and I apologize. I'm not gonna try to put it back because I'm sure I'll mess something up. But, with the financial, it's just, as a social worker or a worker going out into their home, knowing maybe what might be available to them, what services. Would they be eligible for Medicaid? Lots of times I get the folks that self-neglect and they think that they wouldn't be. If they're 65 or older, I always tell folks, oh my goodness, you know what? The income levels actually go up a lot once you hit 65. If it's you and your husband or you and a family member, you can make up to $4,000 a month and be eligible for in-home services. Because in this country, they want to keep you in your own homes with services instead of put you in the nursing home because that's a lot more expensive. Even for one person, the income limit in the state of Iowa for Medicaid, once you hit 65, is $2,200 a month. And I know a lot of folks don't make that, especially when they're living off Social Security and their husband's pension. Then, I went back. I apologize. I think it's really funny because at my job, for some reason now, they think I'm the tech person. I don't know if it's because I've been there the longest, but I always get called to work on the computers. Yeah, that's not me. I'm not the tech person.
We understand that.
Okay. Okay, what to do. When you are working in a particular situation that warrants intervention, it is very hard to decide, what should I do? You guys know that, especially for me, when I'm going out, I have to work really hard lots of times to gain a relationship with a self-neglecting client. That means spending hours out on the stairs talking to them before they'll let me in the house. Talking to them on the phone in my car, which is a block away from their house because they don't want me to see their house. Work so hard to build this relationship and you don't want to be another person who just lets them down. So what do you do to get these people safety? I always think of the social work code of do no harm. How can I best serve this person without putting them under a lot of undue stress? If you believe that somebody is in a self-neglecting situation, it needs to be reported to APS. It's not our job as mandatory reporters to say, yes, abuse is going on, or yes, they are a dependent adult, or a vulnerable adult. We're to show why we think they are, and then it's APS's job to decipher whether or not abuse is actually happening and whether or not they are dependent or vulnerable. We have to respect the client's rights and their freedoms. If they are a competent adult and they don't appear to be in danger, they can live with all that garbage if they want to. And then knowing yourself and knowing your team is also a very important part of working with self-neglectors. The next slide is the numbers that Amanda talked about. And yes, they just last fiscal year changed to the statewide intake center in Des Moines for Iowa. So always call the 1-800 number if you have a case of suspected adult abuse in Iowa that you'd want to report. And that's also the number for the child abuse line as well. You just have to indicate when you call whether or not it's for a child or an adult, because they have different forms they have to fill out. And then the Nebraska Abuse Hotline. Okay, and when you guys raised your hands for reporting abuse, how many of you guys actually have made dependent adult abuse calls? Were those successful? Do you feel like your client got helped?
The girl that I spoke to just took down the information here in Nebraska
Okay.
because it was suspected that her grandson was exploiting her, and there were other concerns because things were missing. And all she did was to take down the information, and she told me, and this is really frustrating because she said, I will enter it in a database, and they're gonna, from there, they determine if there is some kind of an abuse, and if there is, they would do some sort of an investigation. I never heard back from them, and unfortunately, we are no longer seeing a
So you really don't know
I
what
don't know.
happened. And, you know, that's what when I wrote in here, I wrote about the frustration. When I first started this, my God, I didn't know why APS wouldn't get involved. These people, one of my first hoarder guys in Carson, he had roaches crawling in and out of his wounds.
Oh my God.
And APS, look, he's not a dependent adult. Who in the world chooses to live like that and is mentally competent? You know, it's so hard and so frustrating. And then over the years, for my own sanity, having to say, okay, I know that APS, they do what they can do according to state law. And that's all they can do because they are state agents. I work for a private nonprofit. I have a little bit more freedom. So APS has to follow the law when it comes to dependent adult abuse. Yes?
I've had not so much, when I've had like borderline families that there are issues, you know, I've really had good luck dialing 211. They are quite helpful and they ask the right questions to get you to the right resources.
Oh,
Some
wonderful,
families I've had-
wonderful.
And most of mine's been with kids, but I also have some special needs kids, so if they're over 18, then so, you know, I've talked a couple times, it was like not really abuse, but we were worried about stuff, and 211 was quite helpful.
Yes, the United Ways 211 is a very good resource. If
They
you had
ask the right questions to.
they ask the
where
right
you
questions to
need
get
go.
you in the right places.
Going back to that lady that I had to report, there was an incident where, because of her medication, so I had to call the pharmacy, and the pharmacy made 2 attempts to deliver the medication to her, but what happened was, she told me about it, and I told our nurse and the social worker, I don't know if I told the social worker, but her grandson, who was asked to leave, threw a fit, and he ripped the phone off the wall, and he threw it. And that's why they didn't get a hold of her, because they couldn't get into her apartment building. Well, the pharmacy, was nice enough to make a 3rd visit going out there, to deliver the insulin, and there was a question, because we were questioning her insulin and her injection, you know, the pens and all that, and the medication. And I have a feeling that, the significant other might have been doing something too, but, and she came in the house one day while we were there, I mean, you know, and I asked my bath aide to check her body out when you're doing your bath, and she came back and said there was no bruising or anything, but we suspected a lot of things because of what she told us. And it didn't seem like the girl who was taking down the data was, maybe she was just taking down the data, you know, that's all it was. But I never heard back from them, and I don't know what came about on this.
Well,
And
and
I think our nurse also called too.
yeah. In the state of Iowa, if you were a mandatory reporter and you are making a call to the Department of Human Services and you leave your contact information, they send you a letter. They'll say, this case has been accepted and somebody's gonna go out and look, and okay, it's not exactly what it says, but the gist of it is, okay, this has been accepted, we're gonna go out there and see what's going on. And then after that, after they do their social work intervention, then you're supposed to get another letter telling you whether or not the abuse allegations were founded or unfounded. And I apologize, I don't know what the process is in Nebraska. Yeah, but in Iowa, they are supposed to follow up with you. And if they don't follow up with me, I call
And they do, I mean,
them. Yeah.
in Iowa, for those that have reported, and typically we'll get a letter that comes back here to the office addressed to you, so I know our social worker's Jean, I know, she's gotten a lot of letters, so there's some lag time, but at least you know if the allegations were founded or not founded, and again, your responsibility being the reporter, and, I mean, and sometimes that is frustrating, because, you know, if they were unfounded, but again, you did the right thing, and so, at least with Iowa, I know you do get that letter.
But even if that report is unfounded, if they start getting 6 things, it's cumulative, and they're going,
Yeah.
there's gotta be something going on that 6 different people are making these reports, or it has gone on, so
Yeah.
it doesn't, even if they don't, if it's unfounded at the time, it's still in their file, and sometimes that helps.
Yeah. And
down
that's,
the road.
she makes a good point, she just said, I'm not quick, so
No,
it
go
gets
ahead.
on the, she made a good point about, sometimes when you're unsure and that it is unfounded, the point is reporting it, because if you report it and then 2 months later, someone else reports a similar situation, the neighbor reports it, then they have the complete picture. And often that's what they need to then do the proper intervention. So even, again, I know sometimes we're kind of in a state of, I don't know if I should or not, go ahead and make that report, and, because again, once they put the full picture together, it could be that you did the right thing for that patient at that time, so, good point.
Well, and another thing, you know, we are mandatory reporters. There are no sanctions for reporting abuse that's not occurring. Yeah, if you suspect abuse and you report it in good faith, there are no sanctions, and there are sanctions if you do not report the abuse and you're aware of it. So it's very important, like Amanda said, you know, go over your suspicions with your team, and then if you believe that the abuse is happening, then make a report. I did it again. There we go. When it comes to respecting individual rights and freedoms, we have to accept that people are going to have different behavior standards. Not everybody's house is going to be as clean as yours. I get that a lot when we get new case managers at work. They'll say, oh my God, this lady's house is so horrible. And I'll go there and I'm like, what? What do you mean? But okay, I know I'm a little skewed because I've been doing this for a while and I'm used to anymore working with the folks that have their stuff floor to ceiling, but there's a big difference. You gotta remember that folks have different living standards. Recognize the necessity of slow relationship building, and for me that is, you know, spending the time out on the stairs or on the phone with the client so they'll trust me enough to let me in and to see what help we can get them. And mostly be aware of our own views and try to remain objective. Okay. Knowing yourself. I don't know about you guys, but I know sometimes when I get in there, I still have the feeling, oh, I'm going to save the world. So knowing your boundaries. Making sure that you're still taking care of yourself even if you have a high crisis client. I was telling Amanda before we started, I had this fella that I just got a couple weeks ago, and I think I've spent like 80 client contact hours with him. So my boundaries may be a little blurred there, but just knowing what you need to do to take care of yourself. If you have a client that have pests in the home, you know, assess your safety. What are you going to do to assure that yourself and your staff are safe when you're going out to visit these people? You know, one of the things that I've done over the years when I go to people's houses, I don't know if you can, but I don't wear capris and I don't wear the sandals. We can wear them in the office, but when I'm going to go out to see people that I don't know or I haven't seen before, because my husband told me if I bring roaches home again, he's going to kick my butt. But because that's happened a time or two, just making sure I protect myself, and then working with the Council Bluffs City Inspector, knowing that, oh, you can put bug spray on the bottom of your shoes in the tread, and that will make it so you don't track roaches in your house too. So that was a good tip. Knowing when you go into houses that have odors to them, either human, moldy, or because of pets, knowing that maybe a little bit of Vicks underneath your nose takes away that smell and makes it bearable for you so you can go in. Because it's really, really hard when you're going into somebody's house for the first time, and it really stinks. And your eyes are watering to have a good objective assessment with them because of the status of their home. And usually when I do get in those situations, I get the pertinent information I need from in the house, and then we meet outside or meet somewhere else. And I talked about that a little bit, you know, knowing how to protect yourself from the elements. I don't know you guys probably aren't lucky enough to get into some of the cases that I get to where there are the roaches and the vermin, and I have to be there. But you may. Hopefully not as much as I have to anymore, but knowing that, okay, I am going into this situation, I know that I am going into this situation, so what can I do to protect myself? I double up on my allergy meds when I know I'm gonna go into a hoarder's house, that, especially when they're hoarding animals, because I am so allergic to dogs, and it's usually fine. But when they have 6 or 7 of them, it makes it so when I wake up in the morning, I can't breathe and my eyes are all puffy and won't open. So just knowing what I need to do to protect myself and what you guys need to do to protect yourselves as well. And I learned this lesson a long time ago. When you are working with somebody who's self-neglecting, hoarding, or just not taking care of themselves, it really takes a team. It's not a thing that one person can address. You can have Jean going in doing the social work from VNA, and then you have your home health workers. Maybe you have to get the city involved. Maybe you have to get APS involved. Who can we get involved to make sure that this client is safe? In Council Bluffs, we have this wonderful program. It's called PAR officers. They're police officers, but they deal with more of the civil issues. So if you have somebody that's self-neglecting, they can go out with you and kind of talk to the person and say, this isn't good. But knowing who your partners is, and it sounds like with your team meetings that you guys have that covered, and just knowing that if you have a concern to bring it to your team. And really knowing that having engaged partners is really the best way to address somebody that is in a crisis situation.
Went backwards.
Oh, how did that happen? Let's see. Okay. And the hardest part for me is accepting sometimes that these people are adults, they're competent. Everybody else says they're okay, so you have to walk away. Over the years, this hasn't happened very many times, but gosh, I just had a client who I had on my roster since 2006 that I just closed because it was time to walk away. And kind of an example of what his house is full of about 3 feet of garbage. You go through his house and it's like ice skating because of all the magazines and everything. And underneath the magazines, there's boxes of coins and collectible coins, and people are coming and, it's such a bad situation, but he knows his rights. He knows that he doesn't have to let me in the house if he doesn't want to, and he doesn't have to accept help if he doesn't want to. Tried to get the fire department, the police, the city inspector, and because of codes, there's nothing they can do. This gentleman can live this way if he wants to, even though with all this paper in his house, he is a smoker. He has fallen asleep in the one chair he can access in his home, and all the paper behind him and around him is charred. He's fine. And the one burner on his stove that's not covered by all the paper too, that he uses to cook, all the stuff around that's charred. But APS said he's competent, he can live that way. Fire marshal said, nothing I can do, it's his personal home. Police said, yeah, he continues to go to the homeless shelter and pick up prostitutes that steal his money, nothing I can do. Knowing that us as in-home health workers, that we can try, we can let them know that we're available to get them help if they will accept it. But then also knowing that sometimes there does come a point where, as professionals, the people do not want help, and we can't force them to take the help. We can urge them as much until we're blue in the face, but unless they actually accept it, there's nothing that we can do. And it comes a time where we can just walk away. Okay, and I must have spoke fast because that was my last slide. Do you guys have any questions? Yes.
How do you get your referrals then?
How do I get my referrals? A lot of my referrals are actually through DHS. They get a call on somebody, and it's not dependent adult abuse, but they still think that there may be abuse or the client's at risk. I get calls from neighbors and family members, anybody in the community, provider agencies that go out and see firsthand what's happening.
So we could contact
You could contact me, that is correct. I don't know how many of you guys are familiar with all the fun that we're having in the state of Iowa with our budget. I mean, it's kind of like Obama, with all the Senate stuff. Right now, I don't officially have a program, but I'm still doing elder abuse intervention. I don't know how far I can intervene, but I'm going to be able to do that. Let me see here. And I was thinking, of all those clients that I've worked with, those almost 800 clients that are self-neglectors over the years, thinking of the hoarders and how hard that is and how many times we've actually had a successful outcome with them. And I found the only time that I've ever really been able to help a hoarder to the point of them no longer being in a hoarding situation is because they had to. The city was going to demolish their house. The state was going to take their loved one out of the house. I was trying to think of some good instances of being able to help hoarders, and the one was good. We were able to get her dumpster so she could clean, but she did clean, and she was able to keep her husband through his hospice, and he was able to continue with his wishes. Other than that, not so much. Yes.
Do you have funds to get people cleaning supplies, soap?
Yes.
Oh, okay.
Yes.
Okay.
The amount of funds, don't know quite yet. But in the past we have. My thing has been to go out. I'm kind of like the program at last resort. I used to have an assistant, but budget cuts, now it's just me again for my 8-county area. But my thing is to get the folks out of crisis. What do we need to do to get them out of crisis? Do we get dumpsters? Do we get a cleanup crew? Do we get them a payee?
Well, I mean, do you get them soap and things like that?
If they need it, yes.
Because there's some people can't afford that.
Exactly. Well, and especially these days, it's
And there's
so
one
hard.
place you can go and say, I need funds for cleaning supplies, like
Or-
soap, either face or washing soap or.
Definitely, or in Council Bluffs, there was a couple of dry goods.
I know Phillips Pantry is one.
Yeah, and to refer them to them, and I just went there, and they said I can't come back for 6 months. Okay, well, we'll see what we can do to help
Oh,
you.
okay.
I like to take a full hands-on approach when people come in. If they aren't currently on Medicaid or they aren't getting assistance, helping them fill out those applications. Working with the seniors, letting them know that, my gosh, it's all right. You're not ripping anybody off. You do need the help. My gosh, you are going to benefit so much if we can get you in home services. Let's fill this out, because that's what this is here for. Yes.
What's the phone number for Southwest Aid?
328-2540. If you are calling with an abuse type problem, that would be me, and I'm extension 32. Other than that, if you have any aging questions or you have clients that you believe could benefit from some of our services, you just call the main number, and our executive assistant, Connie, will get you to the right person.
Is the hoarding becoming, is it on the rise, or is it just because it's gotten on TV that it's just
I
like
think
more people are-
with the hoarding, and if it's on the rise, I think it's just because more people are becoming aware of it. Where in the past, they just kind of, she's kind of eccentric. She's always been like this. There's a lot more awareness these days about hoarding. And I read somewhere that they say 8% of the population hoards, and I always laugh and say, yeah, they all live in Southwest Iowa. Because when I carry a caseload of 160 clients, and I have 80 of them that are hoarders to the point where it's floor to ceiling, I think it's a lot more widespread than folks know. Yes?
Can we speak your number, please?
Sure. And I don't know if you need it, but 712-328-2540. And we are the local area agency on aging for Southwest Iowa. We have an 8-county area. We have a couple of wonderful new programs. We have a Grandparents Caring for Grandchildren program that I'm really proud of. great resource for those folks that didn't have that resource before, because I didn't know that when grandparents actually raise their grandkids, they don't get financial assistance. I mean, they may get child support from the family, but they usually don't. But if they were in a foster care type situation, you know, they'd be getting the moolah to take care of these kids, but when they're with their grandparents, they don't get the assistance. Yes?
Do you know of a comparable person or agency on our side? I mean, is there something in Etowah that would be comparable to yours?
And it's been a couple years, but I know Diane Stanton used to be a high-risk case manager. She was kind of doing what I did, but here in Omaha. I don't know if she still does or not, but Diane's been there forever and she's a wonderful resource. Yes?
Have you ever been involved with carboarding, where people are living in their cars and all you can see is the spot for driving?
Yes, and usually, to me, that's if they're not living in their car, but they have a lot of stuff in their car, that's a big indicator that, you know, their house probably looks the same way. But when you have the folks that are living out of their car that are like that, I have dealt with that, and DHS said they were perfectly competent and okay to do that if they wanted to, so there was nothing I could do because they refused help. Now, do you guys oftentimes, do you deal with people that are living out of their cars, or?
Yeah,
Sometimes.
I'll stuff all over from school.
That's different.
Do you guys, yes?
I think it's a growing trend, and I think I've had a relationship with two clients that you were referring to in Council Bluffs, that it's a growing trend that a lot of times it's not due to financial reasons, it's self-neglect. The family members will give their stamp or their DBT card to people, family members, or they'll say, here, use my check, pay for your items. Especially older adults, they want to take care of their kids, their grandkids, and APS will not step in. We know that they're being violated financially or twisted or whatever, but since they're a competent adult, you know, APS will not do anything, but we're seeing more and more of that.
Yeah.
They
Well,
live
and
in the house because they've given a food stamp card to somebody to use, they've maybe given half of their check so then the rent doesn't get paid, and I'm seeing more of a trend of that.
exactly, and I just remember too, it's not because they won't get involved, it's because they can't.
Right.
If the people are choosing to do this, it's very hard to get the state involved to tell them it has to stop. I mean, I've had folks all over where, you know, they'll give their daughter their food stamp card the first of the month and then think, oh gosh, how am I gonna get groceries the rest of the month? Well, so, you know, working with folks takes a lot of patience. So just knowing that and helping them and knowing that they can make their own decisions no matter how bad we think they are. I recently did tell one client, you are 71, not 17. Why don't you start acting like it? They did not like that, but they did let me come back again. But,
I know it can vary, but when and how do you get mental health involved?
I've had instances where we have folks that can't go back home, so we try to do the mental commitments. They have a new wonderful program in Council Bluffs, the ACT program through Heartland Family Services, where they go out and do crisis intervention for people with mental health issues, and I've actually been called in by them. I find it the hardest for me to deal with people that are mentally ill because I do not have the specific training in that, even though that seems to be the biggest referral I've been getting these days. And it's hard, you know, knowing what do we do? You know, where do we take this person? And the ACT team is a good resource. And if you ever need to, Sarah Morrison, she's at the Lincoln campus, give her a call. Jean, and she can be a good resource. Yes?
There is an ACT team in town here through the Community Alliance.
Oh, okay, so there's an ACT team in Omaha as well?
Yes.
Full-time one, not a half-time one.
Full-time one.
Oh, I'm sorry.
Okay, well, and I think that Heartland Family Services has the ACT program as well
Yeah, it's.
in Omaha.
The purpose of the ACT team is to keep people who have had a lot of hospitalizations from going back into the hospital.
Okay.
So they really have to have a kind of a high level of mental health needs, and then they can come in and offer community support worker services and that kind of thing. So they have to jump through some hoops to come in, and Magellan in Iowa.
And I was told in Iowa that they only accept place referrals, but they have been a good resource. If I have somebody, they can point me in the right direction of where to go.
Going along with that Salvation Army, those community support workers, and we'll work with those that are volunteer or referred by inpatient hospital facility for mental health. They will follow people into their homes as well.
Oh, okay, great.
Salvation Army community support.
And she was also saying the Salvation Army is a good resource. Now, besides Jean, how many social workers do you guys have that go out into the homes? There's two of you?
Well,
Three?
a couple more.
Three?
A couple more that are.
Two more.
Yeah.
Two more in hospice. And just knowing your social workers, they're your best resources. Okay. Anything else? No? Thank you guys so much. It's my pleasure to come and speak with you.